Okay, so I'm doing a live Google Hangout, and I should be joined by my friend Matthew momentarily. So the topic is healthcare, what's wrong, and how to fix it. I'm sort of trying to, I'm waiting for Matthew to join. But basically, Matthew and I have been talking about this for a while, and we decided to do a hangout to talk about this. And this is my first time with Google Hangout, so it's not working properly right now. And I don't know where he is. Okay, I'm gonna. Inviting him again. Hopefully we're going to be able to edit this.
Well, now I'm in. Aha! Success?
Oh, hey!
There we go.
There we go. Okay. I have no idea if this is going to work, but it looks like it's working now.
It
Okay.
does.
So we're going to
Just like
talk.
most healthcare reforms.
Exactly, topical. All right, so we're going to talk about healthcare and how it's screwed up and how everyone is screwed up about it. And we should talk about it, and you're an interesting person to talk about it because you are.
I am a primary care doctor. I work in Baltimore, Maryland. I just finished residency, which is sort of where a lot of the fault lines in the healthcare system can kind of be exposed,
Right.
because you see a variety of things. And I'm about to work for an organization that exclusively takes care of the homeless population, which is another very interesting place to
Right.
work.
Right. Okay. So you were basically in the sitcom Scrubs,
Yeah, pretty much.
which is pretty much what
Although,
I know about the U.S. healthcare system.
yeah, no, I have only watched a couple episodes of Scrubs, but everything I've read about it says that everything that I've seen is actually, it seems pretty accurate. Um, Except usually our lives are a little more tragic and we're all a little more tired. None of us look that good.
Okay, and so just to introduce myself briefly, I'm Pascal-Emmanuel. I have a market research company called Newsfeeder, but more relevant to this, I write things on the internet, which makes me unique. Uh, in particular, on on the Catholic channel at the website Patheos on religion, and on economics, policy, politics, that sort of thing at various places, including Forbes and Up and other places. So that's the idea. All right, so we've introduced ourselves. So one of the things that is, so I'm going to introduce it that way. From my perspective, one of the most frustrating things with the healthcare discussion in the U.S. is that it's not so much that people have the wrong solutions. They have the wrong problems to begin with. And one of my sort of obsessions that I come back to is this theme of doctors are history's greatest monsters.
Yeah, well, I mean,
Uh,
I can, I mean, then again, I'm a Calvinist, and that whole total depravity thing just fits right in with that. But yeah, no, I think that there's a lot that a lot of problems in the healthcare system that you can attribute to doctors, you know, being, uh, it's rare that it's sort of out and out malfeasance, so
right,
much as it is just uh, that unique combination of power, ignorance, and the wrong incentives, I should say.
right,
Because I think in a lot of cases, most doctors are interested in helping others. That's why they get into the profession, and that's why a lot of them keep doing what they do.
right,
And they do enjoy helping others all day long, but they are incentivized to make poor decisions sort of across the board, and that leads
right,
to global problems.
right. So so my perspective on this is there's a couple things. There's this sort of kind of philosophical, sociological, and kind of Christian thing,
Hmm.
and then there's the economic thing. So
Yeah.
the more philosophical or sociological thing is I, you know, in many ways in our culture, doctors have replaced priests.
Absolutely.
And so we collectively have this myth of the doctor as, invested with magical powers. And there's an inherent asymmetry in any relationship with a doctor in terms of knowledge, but also in terms of power, right?
Oh yeah.
If you're at the ER at a hospital, everything about your interaction with the doctor is designed to sort of make you feel powerless.
Hmm.
And
Yeah.
not necessarily voluntarily designed, but the way it works is this is a thing more in the United States than in France. But for example, the fact that I find absolutely striking that you have to undress for a physical exam, even though in most cases you don't really have to undress for like 95% of it.
Hmm.
Uh, things, and that's just a tiny thing of this broader thing, which is um, this myth of the doctor, and I think it has created this sort of self-perpetual dynamic, whereas the doctors buy into the myth because it's flattering
Hmm.
for them, and so the medical profession tends to attract, statistically, blah blah blah. Not everyone's like that.
Right. Yeah.
Plenty of
Yeah.
doctors are
Hmm.
saints and blah, blah, blah. But certainly in my own personal experience, and I haven't seen anything to counteract that. Most, the vast majority of doctors that I've encountered have tended to be sort of basically assholes, and I mean there's just no other word for it. It's either that
Sure.
or
Sure.
God
Yeah.
complex.
Now, have you?
And
I guess we should have clarified this. Are these most doctors in France or in the United States that you've encountered,
well,
or both? Or
I haven't actually ever received healthcare in the United States. I believe.
okay.
I'm pretty sure. Next time I go there, if I'm hit by a car, I'll let you know. But
Okay. Yeah. No, that'd be great.
how that went? No, it's mostly my experience in France, but
Hmm.
I know everything about America because I consume American pop culture, and so
Right. Yeah. Yeah. No. And I,
I certainly, it certainly hasn't struck me that there's this big disconnect between the kinds of people doctors are in the U.S. versus in France.
yeah. I mean, I think it's probably there's a few more. I think the pool is tilted a little bit more towards the assholes in France just because of the way that the educational system works. In
Right,
America, at least in the last, I, I'm not sure exactly when this started, probably around 10, 15 years ago, they really started to realize that this was a problem.
Right.
And they actually started to really make a push across medical school admissions committees, because that's really where you get to filter out the assholes from the non-assholes, and
Right.
really build in people, like start training and looking for applicants who
Right.
didn't just get the highest scores, and start realizing, hey, maybe we should have some people that are like good at talking to people. Now, the rest
Right.
of the medical school teaching process, that's really a lot more hit and miss around sort of our, once you have a substrate that is theoretically better at talking to people and
Right.
compassionate and empathetic and all of that, are you putting them through 4 years of medical school and then 3 to 7 years of residency that amplifies those traits, or
Right.
or sort of sucks them
Yeah.
out of you.
Yeah. Yeah. Yeah.
And so that will also really vary from specialty to specialty, and even program to
Right.
program.
And there was this this thing a long while back. There was this Republican politician named Bill Frist.
Hmm.
He was a sort of rising star of the Republican Party in the 2000s, and he was a surgeon. And a thing came out that when he was either in medical school or I think in residency, he would capture stray cats to do experiments on them.
Yeah.
Sort of practice surgery, and there was an article where they interviewed somebody who was a surgeon, and I don't remember the exact quote, but basically like, you know, he was a surgical resident. That's what they do. Like that was like, if the subtext was sort of more like, if you're the kind of guy who gets into Harvard Medical School and gets into like competitive surgical residency or fellowship or whatever, you're just going to do everything to succeed, including like spend your spare time practicing surgery.
Yeah, yeah, no,
And
that's and
to me, that just sort of embodied, you know, the combination of the sort of hyper competitive aspect of like medical school and all of that, and the sort of mythos of the doctor, and the sort of overall system and the way that they combine to sort of create these monsters.
yeah, yeah. I mean, I think that that's a really real thing. Um, Although, personally, all the surgeons that I work with are
Not
very nice. Now, I'm
sociopath.
at a community hospital, which is a
Right.
slightly different world than the academic medical centers, where
Right.
people, where I think that more
No, I mean,
along the
again,
lines
this
of
is
that.
not,
So
100% of doctors. Or,
right. Yeah, no, but um, I think to me there isn't a, a lot of doctors, I think, don't understand that whole like power differential thing that you were
yeah.
talking about. Like, even if maybe they had to write an essay about it in medical school, like they were thinking about passing their test,
Right.
at that time, when they were writing that essay. So really, any attention to the, what we'd call like the humanistic elements of medical
Right.
practice, at least in training,
Right.
or I should say in medical school, are not emphasized unless you happen to like go to a school that really has decided to put a high priority on them, and
Right.
sort of actively encourages the development of those skills. And
Right.
usually that is within programs that have a very strong primary care emphasis.
Right.
But even within that, there's still a lot of kind of skeevy things that go on in that, like you don't, any conversation that you have around the either the politics or the sort of the socioeconomic determinants that would that kind of drive a lot of the pathology that you would see.
Right. Right.
Again, especially in academic medical centers that tend to be in inner cities or other places where there are a lot of poor people and a lot of the medical problems that come along with being poor.
Right.
It's a lot of it is kind of like, oh well, I guess maybe you should go down to Capitol Hill and advocate for some different policy or something like that.
Right.
So there, there's very few places that I think really try to actively recognize what's called the hidden curriculum. The official curriculum may, and it's by now I think it certainly is in most places. Hey, you should be nice to your patients. You should be empathetic. You should not be an asshole. But the hidden curriculum, which is driven by, sort of that power differential and the way that the money gets sloshed around, is, still alive and well.
Right. Right. I guess that's a nice segue to the sort of second aspect, which is, I've been able to get this off my chest and rant, which is the sort of more concrete public policy aspect, which is that doctors are welfare queens, and
They are.
They are, and I mean, this is the sort of striking thing about the Obamacare discussion. Before that, the sort of Clinton care discussion is, the sacrosanct thing is your relationship with your doctor, and the entire debate is nobody's going to get between you and your doctor. You're going to keep your doctor if you like your doctor. And both sides, agree that that's important, right? The Democrats say, no, you're going to get to keep your doctor. The Republicans say, no, you're not going to get. But in every case, this is viewed as the fundamental thing. And
because there's evidence behind its cost effectiveness. And
sure, no, I mean the fact that it's good for people to have a doctor that they have a relationship with and that they know and so forth. But the sort of mentality where, there's sort of, the idea of, hey, we're going to have a death panel that's going to say, this procedure is too expensive, so you're not going to get it. That's viewed as less important. Whether or not it's true that it's actually a death panel, that's viewed as less important than the sort of almighty doctor relationship. And what that produces in terms of public policy, which is the point I was getting to, is that there's a medical cartel. The number of medical school spots is limited and has been limited. I don't remember the exact figures, but it's been the same for 50 years, even though the population has grown. There's, a zillion procedures that only doctors can do, even though there's no scientific reason.
Right. Yeah.
And it seems to me, I mean, and there's a lot of evidence that everybody is sort of tearing their head out over the cost of healthcare, and that this is a huge driver. This is a huge driver. But nobody wants to talk about it because the doctor is sacred. And because the doctor is sacred, he's been able to sort of get Congress to erect these protectionist mandates that then warp everything. And the problem is, when you have a discussion about can you keep your doctor, and that's the whole discussion. Even though it's important to have a doctor and to have a relationship with you, I'm not saying that doctors are complete, you can't even say like, hey guys, like let's, not even be as crazy as saying, let's get rid of medical licensing, but at least, let's say, hey, nurses can do this now, or hey, let's increase, medical school spots or whatever.
Yeah. Well, I think there's sort of two, I mean, I think you're absolutely right, and there's sort of two elements to that. One is the very basic element is that when you have a hundreds of thousands of people who are getting paid a lot of money, and then you talk about any kind of policy that would cause them to not get that much money anymore, they're going to fight tooth and nail. As I'm actually working on another article for
Right.
a satirical site actually about that, about how the needs of our nation just happen to coincide with the interests of whatever particular specialty group. But that's also kind of another, and again, I hate to keep casting the primary care docs in. Well, I'll just go ahead and tar them all. That there is a lot of internecine strife between sort of the primary care doctors and the public health practitioners who are in general more likely to advocate for things that they believe will be good for their patients, who although they definitely are all up in the protectionist thing. I mean, I think there's a significant minority of primary care doctors who do not care if nurse practitioners have independent licensing, although that seems to that's like one of the issues that sort of gets brought up a lot, and I think in the grand scheme of things is going to be a tiny fraction of healthcare costs reduced, because the number of independent nurse practitioners who would then go do, say, rural primary care and bring down, because that's definitely a cost thing of like, and an access issue. But if you look at sort of how people split their time, I don't think nurse practitioners are going to be any more likely to go, provide all that care for people that need it that doctors aren't already doing. So yeah, but there's a lot of the trade, or every trade organization is working for its own interests as well. But there are some trade organizations that are certainly more interested in retaining their particular piece of the pie, and in when you have the disconnect, or the discrepancy, I should say, between American utilization of primary care versus subspecialty care. And the subspecialists, of course, are going to be doing more of those expensive procedures and blah, blah, blah. It's pretty striking how much more we pay specialists. There's not a huge difference between how much we pay primary care doctors versus how much you guys over in Europe pay your primary care doctors. You pay them a little bit better, so that probably helps.
Really?
Yeah. I think that it's a difference. It's an average of maybe like $20,000 to $30,000 a year more. I don't remember the exact numbers.
Because my impression was that doctors were a lot better paid in the U.S. than in France.
I mean, we can always look it up later. I mean, you could say on average, doctors are paid better in America, but that's because you have a lot more cardiac surgeons and
it's a specialist
surgeons who are being paid $500,000 to $800,000 a year, versus fewer primary care doctors who are being paid $150,000 to $200,000 a year.
Right. Gotcha. Yeah, because in France, primary care doctors can sort of be in the quasi-free market where they can charge a lot of money, so that drives up the average. Some of them, anyway. Yeah. Sorry about that.
Okay.
I mean, this might be sort of our segue to this sort of next topic, which is, what else besides doctors is wrong and what can we do about it? One of my fantasies is there should be a job, a profession, which doesn't exist today, which is somewhere between a nurse and a doctor, which is as much about where the sort of training and practice is as much about sort of psychology, public health, preventive stuff, and so on, as much as it is about sort of quote unquote actual medicine.
Right.
You pay this person a sort of monthly subscription. It's like, and they're your, primary care person, general practitioner, however you want to call it. They're your sort of frontline medicine person. And because they don't spend 10 years in higher education, which would cost less to educate them and stuff, because it's not just about being a doctor. There's sort of people who help you, not just, first of all, who are nice, and second of all, they help you with your lifestyle and so on, and they're not, if you need to take care of a child, that's okay.
Oh, no, she just wandered in. So, Naomi, you just have to be really quiet, okay?
Welcome to the internet, little girl. Once you're in the system, you can get out. And, because a doctor will always tell you to work out more and eat less. And they're always going to be such a jerk about it that you're going to eat more and work out less as a result.
Yes. Yeah. Well, and that's because we spend, hours and hours and hours talking about the genetic causes of diseases. Oh, hey, Naomi, you gotta get with Mom.
This is adorable, by the way. Don't be.
Isn't she? Oh, can you play Papa Kiss? I love you. Right.
This is adorable. I was afraid my cat was going to do something similar. It would have been
Yeah. Naomi and Michelle can do this in a couple of years and talk about, why their dads are.
Why their dads are crazy.
Yeah.
Yeah, and so anyway, just to finish my thing,
sure.
If it's a subscription business, it's like, gyms. The business model of the gym works on the assumption that a large number of people who buy gym subscriptions never go, right?
Right.
And that's how they make their money. And so, if you had that person having, let's say 100 clients for Simple, you would have a bunch of clients that you would never see that would subsidize A, the hard cases, and B, the poor. And you would, from the sort of systemic perspective, I think it would work in a bunch of very, very good ways. And of course, if you have if you have a serious sort of medical thing, that person will refer you to a doctor, to a specialist, to a hospital, to a clinic, to whatever. Seems for me, from the perspective of the system, it would really work. From the sort of perspective of the individual, it would be a lot nicer. And it's just not even anywhere near the picture. A, because of the myth of the doctor, and B, because it would be illegal to do something like this. Like, literally, if you tried something like this, you would go to jail.
Yeah. No, and I mean, there are business models that are sort of experimenting with that. There's actually one that I was really excited about in Maryland because the person that is doing this thing or the job that you describe is called a health coach. So they're missing that level of medical of authority, to say, well, you have uncomplicated hypertension. I'm going to make sure that you don't have kidney damage right now or something else really horrible that's causing your blood pressure issue. I'm going to talk to you about what lifestyle changes you can make, and I'm going to prescribe you the medicine. It's that prescription power that's still sort of hung up with the doctor. And so all these models are still very doctor-centric. That everybody gets to see the doctor. And I just wrote something about this the other day. Like there are lots of people who have a high school or a community college education that are smart enough that they could do a fair amount of my job every day. Now I have bad luck, and so I just have a patient panel full of people that have a lot of really challenging, complex medical decisions. But everyone's, I still spend a fair amount of my day doing things for people that anyone with a high school education or a community college
Right.
education could do, and could probably do better than me,
Right.
because they would have a more focused scope of practice
Right.
and hopefully more training around the behavioral side of
Right. And
motivational interviewing and all that.
yeah, and that's the flip side of it, which is that,
Hmm.
I forgot to mention it because I hate doctors and everything they stand for. But yeah, like such a system would also be good for doctors, at least in the long run, because
Hmm.
they would be able to spend their time on more challenging medical stuff and less time on sort of everyday stuff that is, beneath them from a technical medical competency perspective,
Yeah,
even though they
absolutely.
behave like it's beneath them in other ways.
Right, right.
So
So
yeah,
then,
absolutely.
yeah, so then there's two sort of, uh, like, once you get past sort of the protectionist
Right.
aspect of it,
Right.
I think then there's sort of two challenges beyond that. One is that you sort of mentioned that in a subscription model, there's sort of a certain number of people who don't ever really engage that kind of subsidize. And
Right.
it, so one is sort of how to how to get those people to ever buy in, period.
Right.
Um, and two is how to structure the system such that the people who are poor can um,
Right.
a afford it,
Right.
and b that they can um, then then get like the prescriptions that they need, because that's sort of the
Right.
other big
Okay.
um, that's the
Okay.
only, that to me, the prescription issue is the one thing that I keep sort of
Right.
banging my own head against in
Right. Right. So so on the first thing on how to get the sort of people who don't really need it to still pay for it and subsidize everyone else. I think people would pay. I mean, speaking for myself, right? I'm a sort of
Mhm.
generally healthy mid-20s guys, and your typical invincible, as health policy people say, sort of young, healthy.
Yeah.
Uh, I haven't seen a doctor in literally years. I mean, except when I go visit
Good
a
for
doctor with my
you.
daughter. I also
If
avoid
you
them like the
accidentally saw a
plague.
doctor, you might like get something done to you that you didn't need, or tested for
Yeah,
something that you didn't
exactly.
want to know about.
And because I'm in France, I wouldn't get to pay for it, or rather, I would get to pay for it, but indirectly. I
Right.
actually pay a lot more in the medical system than I get out. But anyway, that's another.
Right.
Um, I would still pay for something like that, just
Hmm.
you know, as just to have the sort of peace of mind. There's a sort of insurance quality, but real insurance, not medical insurance.
Right.
Of hey, there's a person I can call, and it's a person who even though I haven't seen her in 2 years, like she knows who I am. I've met her
Right.
before. And and if there's something I can call her, that has a real value, and I think there's a lot of people like me who would sort of pay a reasonable, whatever the amount of my cable bill or something like that is
Right.
for that.
Yeah. And you do
Uh,
have to get with that. You have to build in such that you have like instant access to acute care services, because this is going to be the next sort of big um,
right,
cost thing, or that people are working on, is that patient first, even though it's just really terrible for the medical system in general, because
right,
they overprescribe and they overtest, and it's totally disconnected from whatever is happening in your primary care world. Patients love it because it's easily accessible, and
right,
you get an antibiotic every time you have a cold, even though you don't need it. And so
and thereby
you have to
destroy the human race over the long term.
yeah, and so you have so you have whatever your this sort of ideal primary care worker is going to do, they probably have to be able to treat a wide variety of these.
Right. And
Patients.
there's no perfect system.
Yeah, no.
And I don't, I agree with you that there's still a problem. There's still some ways in which it could sort of be wonky, but
Right.
it would seem to me to be a big step forward. Now,
Yeah.
to sort of second thing about the poor,
Hmm.
I would sort of say a couple things. In sort of
Yeah.
my real utopian world, the people I've just described, the sort of job I've just described, it's
Hmm.
all nuns. It's nuns. All right.
Yeah.
So everybody knows that it's sort of pay what you want.
Hmm.
Sort of like if you can't pay the sticker price, like that's okay. They'll take care of you when sort of people
Hmm.
know that.
Yeah.
And number two, because they're nuns and they've taken a vow of poverty, they sort of work 6 days a week, 12 days good, and it's really cheap.
Yeah.
And by the way, healthcare nuns are awesome. Like
Oh yeah.
my daughter was delivered in a hospital run by nuns, and they're amazing. Everything. They're like the flip side of the awful doctor portrait.
Yes.
It's amazing. So that would be number one. The sort of less sort of requiring a sort of total cultural revolution would be to say let's have vouchers, right?
Yeah.
Let's just do it on a voucher system, and that way that takes care of both the problems, because people like me, like if it's a voucher, it doesn't cost you anything, so you do it, and
Yeah.
the poor get it.
Hmm.
That would be sort of my answer.
Yeah. And how about the prescriptions?
Right. So, damn you, you have good questions.
Yeah,
Well,
because no, this is like I totally track with David Goldhill on like all this kind of stuff about like healthcare costs are just like any other costs, and people buy refrigerators and people buy houses, and I'm like, yeah, no, I totally get you on that, but there's some people that have to buy a refrigerator every month,
right,
and and
right,
and that's a really hard thing to build in, and
right.
yeah.
Yeah, right. So we're getting into Gold Hill, and that's the sort of nice segue into the sort of broader systemic discussion. It's,
Hmm.
you know, let's give everybody a health savings account.
Hmm.
Let's let's have 10% or whatever in your paycheck go on it every month. If you
Hmm.
top it out, it's money in your pocket, so you have an incentive to spend less.
Hmm.
If you're below a certain limit, the government tops up your health account. If you have a chronic condition, the government tops up your health account.
Hmm.
And out of your health savings account, you also buy catastrophic insurance for,
Yeah.
when you get hit by a truck, or when you get sort of really serious cancer or whatever.
Yeah.
And again, it's not going to be a perfect system, because
Yeah.
okay, so you have diabetes, so how much do we top you up? Oh well, there's going to be a government formula and blah blah blah, and the sort of
Right.
drug companies are going to get in there and set up the formula and blah 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 blah.
Hmm. Yeah.
But there's sort of, again, no system is perfect, but I
No.
really think that if we get that, the sort of Singapore Gold Hill, for people who are watching who don't know, just Google David Goldhill, How American Healthcare Killed My Father. It's an article written by this guy, David Goldhill. He turned it into a book. You should also buy the book, but you can just read the article for starters, where he sort of describes the concept that I just talked about. So health savings accounts for roughly everything, plus catastrophic insurance, either sort of government-run system, but just for catastrophic stuff, or sort of the voucher for whatever. That's a detail, but the idea is, for catastrophic stuff, you have insurance. For everything else, you have health savings account. And And for the poor and chronic conditions, the government tops you up. But it's a consumer-driven system where the money's in your pocket, you drive the decisions, and the overall thrust of the piece is the myth is healthcare is unlike any other sector of the economy, and Goldhill says, economically speaking, it is actually, there are some differences,
Yes.
but mostly, it's like you just said, it's like refrigerators, it's like cars, it's like, if we decided to manufacture and sell cars the way we do, I mean, we actually, it's not a conservative rant, like, literally, we actually tried making cars the way we deliver healthcare, and that was called the Soviet Union. That's literally the case. Like that's
Yeah.
you got when you were in a big sort of government, when you were in a big company, the government would buy a car from you from the government manufacturer, and you had no role in the decision. It was all these big mammoths talking to each other trying to make a car, and lo and behold, the cars were all terrible and really expensive, and they completely unrelated to what people wanted or needed.
Mm-hmm.
So, and I mean, this is just the sort of bracketing to sort of explain to people
Right.
that you and I are talking gold hill blah blah because I've sort of beat you up over the head with this on Twitter, but so that's what we're talking about. Go look it up. So yeah, I mean, basically, I really do think that the sort of, Gold Hill system is, or which is also the Singapore system, because this is how it actually works in Singapore, and
Mm-hmm.
Singapore has the best and the cheapest healthcare in the world.
Yeah.
Roughly
Yeah.
speaking, I mean, it's the World Health Organization ranks them 5th in the world, which is like, oh, it's not number one. Yeah, that's pretty good.
Yeah. Yeah. Who because I was trying to figure this out. Who gets to decide what can be bought with your HSA in Singapore?
Right. That's also, yeah. And there's that's a big that's a big problem, because I mean that's a real problem, because hey,
Could I get hair
we're
implants
right,
with
we're,
my
we're probably
HSA?
not, probably shouldn't let people use their, I mean, you can sort of use this, I mean, if you can use it for anything, it's no longer a health savings account, it's just a
Right.
bank account.
Right.
So you can go full libertarian on this, and yeah, it's probably not a good idea as a matter of public policy to let people buy like homeopathic remedies with their health
Right.
savings. But
But at the same
once you've
time, you might
established that
also
principle,
you might also
what?
say like, um, if there's a child with asthma living in a mold infested apartment, you might want to
Right,
say like you want to give somebody, probably a doctor, the
right,
power
right,
to say, if you use your HSA and go get your carpets ripped up,
right. Yeah,
which is again sort of one of those things that it's about sort of the balance between
yeah.
flexibility. Doctors are as powerful as they are because they need some flexibility to do certain things,
Yeah, yeah. No, that's
but
true. That's true. I mean,
they've
again,
gotten out of control.
yeah,
Yeah,
yeah. I mean, there's really no perfect system. I
right.
guess my idea is a sort of instinct there would be, let's do it on a state by state basis,
Yeah, no, I think that's
and
perfect.
sort of figure it out as we go, and sort of
Hmm.
have 50 different systems, and sort of people can compare, and you're
Hmm.
going to have systems that are going to turn into, the doctors are going to say, hey, use your HSA to rip up your carpet, and the doctor is a shareholder in the carpet ripping company or something. But you know and just sort of muddle through, and because yeah, there's never going to be a sort of perfect system. The other thing I would say, which would be the sort of you know heartless conservative thing, would be
Hmm.
to say, uh, some people are going to be able to afford to rip up their carpets, and other people aren't.
Right.
I mean, it if we take the sort of Honda, the sort of car analogy for healthcare,
Hmm.
I think, there's our sort of collective duty as a society
Hmm.
is to ensure that, everybody gets like a 10-year-old Honda. Not everybody gets a Cadillac.
Right.
And, not because, conservatives enjoy being mean, but because
Right.
we live in a world of finite resources. And
Hmm.
if we start with the idea that everybody's going to get a Cadillac,
Hmm.
uh, it's just not possible.
Sure.
And, I mean, there was this family I knew where one of the husband had an aneurysm and was mostly paralyzed, and
Hmm.
the French government paid for an enormous amount of stuff. They paid, not just for sort of speech therapy because he had to learn to speak again, but they paid for a specialized nurse to visit him every day, and a
Hmm.
bunch of stuff. What they did not pay for was the fact that the family in question, which was quite well off, sort of tore up their entire house so that he could go everywhere in his wheelchair. They put up elevators. They redid the
Hmm.
entire bathroom. They blah, 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 blah,
Right.
blah. It really improved his quality of life, and it was a really
Hmm.
good thing that they were able to do this.
Right.
At the same time, should the taxpayer pay for that for, I mean, if we decide that's going to be our level of sort of commitment,
Sure. Yeah.
there's just sort of no end to it. And yeah, I mean, the sort of libertarian economist Tyler Cohen got into a lot of trouble by saying, there's a fact about healthcare that nobody wants to admit it, which is that, the rich are going to get better healthcare and the poor are
Hmm.
going to die sooner under any system.
Hmm.
And again, I'm not gloating, but it's just a terrible fact of life. And we should, you know, in my mind, the priority is 100%. Let's do the best by the poor.
Hmm.
Let's do the
Yeah.
best that we reasonably can.
Hmm.
But you know, I do think that if you sort of have the mental model where everybody gets the best healthcare in the universe,
Right.
it's just not going to work. And if you look at countries like France or the NHS or the NHS in Britain, the rich still do get better healthcare because they opt out and they
Right.
get off to other countries. So it
Hmm.
doesn't even accomplish the goal, but
Right.
it sort of immiserates lots of people. So that
Yeah.
I'm being cruel, but
I mean, I don't think it's being cruel to say that the rich will always buy something that they think is better.
hey, that's
And
also true, right?
yeah, because the whole concept of the executive physical just terrifies me that you're going looking for all sorts of problems that
Right,
you know once you find them you have to try to fix
right,
them,
right,
and that
right.
can
And
comes with all
you
kinds
know,
of harm.
yeah, and the difference in quality between a 10-year-old Honda and a Cadillac
Hmm.
is not as big as the difference in price, right? Most of the difference in
Right.
price is just, mental masturbation. And sort of, I'm the kind of person who drives a Cadillac. And, like,
Hmm.
yeah, exactly. It's good that, because for the car company, so Honda and Cadillac aren't the same company, but like Toyota,
Hmm.
Lexus subsidizes the sort of the cheap Toyota cars that
Hmm.
people drive around because
Yeah.
human beings are vain, and so they buy Lexus, even though
Hmm.
a regular Toyota would have been just as good, and it's the same car under the hood, but it's just a different
Right.
logo, and that subsidizes the sort of middle and working class cars.
Hmm. Yeah.
But at the same time, sometimes the Lexus has, technology that, will save your life in a certain type of crash, whereas if you got the cheaper car, you would have died.
Right.
And how do you balance the sort of, on the one hand, the Lexus makes the middle class car cheaper versus on the other hand, the Lexus might in some circumstances, you can't make those sorts of decisions sort of godlike from Olympus
Right.
and say
Right. Yeah. No, you can. I mean, you can look at mortality data about certain things, but then that sort of leads you into what I think our last topic was, which is thinking about
Right, and
how.
we're sort of already running out of time.
Oh yeah. Oh.
So we've got a few minutes,
Yeah.
but we, we,
Yes.
we
Sure.
sort of out of we used 90% of the time for what was supposed to be 2/3. Okay, sorry. Go ahead.
No, it's okay. I was just gonna say that when you get into the things that keep poor people sicker and dying earlier,
Right,
you start to get into a lot of issues that don't really fit into the delivery of medical care.
right,
Um, Jeff Brenner from the Camden Coalition, who is really trying to shake up a lot of things, and I think has a lot of ideas that are pretty contiguous to what we've talked about in terms of, taking power away from the rich, arrogant doctors. Tells a story about how he went to a public housing project, and he sort of, drew some things up on a marker board, and he was like, the average resident here got about $60,000 worth of health care. Like, you take the grand total of however many $100,000 and you divide it by the, 200 residents in this place, and you all got an average of $60,000. Who here felt like they got $60,000 worth of health care
right,
last year?
right,
And, everyone's looking around like, what?
right,
And so many of the things that drive the poor health outcomes are things that are way outside of any sort of medical silo, even to the degree of thinking about, health coaching and talking about,
food,
eating right and exercising. If
right,
you live in a neighborhood where it's not safe to exercise, then what are you going to do? If you lead paint was huge issue, and still is today in Baltimore, and I'm still taking care of kids who are now getting into their teens and 20s who are severely affected by lead. It's about urban design and lead paint and smoking, huge public health
yeah,
issue. And that's where you really start to see the libertarians shriek when you talk about adjusting, changing policies that
right,
you would hope may help improve public health. But even that is still, because you have to use some sort of government levers. But I'm also wondering, as more of a free market conservative, if you think that there are ways that the free market can be
yeah,
utilized against
right,
these public health demons.
right. I mean that, and the public health thing is also really important because it distorts our sort of healthcare debate because you know there's sort of here's a true message about healthcare. You know, if you stop eating junk and you secure your guns properly, you will
Mm-hmm.
live longer, fatso. And if that's your healthcare agenda, people aren't going to vote for you.
Right.
But if you say, vote for me and you'll have healthcare, people will vote for you.
Yeah.
And so, right, it's part of the sort of the big one that everybody talks about is obesity. And to my mind, it's a really big question whether it's a sort of government-driven problem, culture-driven problem, something else-driven problem. The sort of libertarian argument, which I'm not fully convinced by, but I also think doesn't get enough play because I think
Mm-hmm.
it's a smart argument and it's just not part of the conversation. Is that the various sort of farm subsidies, we subsidize sort of the worst forms of sugar, for example,
Oh
and
yeah.
the ones that cause the most fattening are the ones that are most subsidized. So it's the ones that end up, in soda and junk food and all the rest.
Mm-hmm.
So all of these ways, and because we subsidize sort of big ag, of real food becomes unaffordable, and so it's I'm I definitely think it plays a role, and I definitely think we would be better off on so many metrics if we sort of, torch the Department of Agriculture, sort of right after we torch all the medical schools. Uh, but, does that account for the whole problem? I'm not sure. Uh, and the other thing is the sort of conservative thing, slash also libertarian, which is, there's a real question of sort of government intervention when you say, well, we're going to take away your big gulp or whatever.
Mm-hmm.
To me, there's a real question of, regardless of whether it works, which is a big question because it's not simple as, we're going to take away your big cup.
Right.
I do think there's a problem when the government says you can, like you're going to eat your vegetables, basically.
Right. Yeah. No, that's.
I mean,
Yeah.
the other reason why people don't talk about it is because it's so hard. Like it's, nobody knows really why there is such a mess and what we can do about it.
Mhm.
So.
Yeah, and it's interesting that you talk about that as being a really libertarian argument because the only people I ever hear talking about sort of the evils of big ag are the soft-hearted, soft-headed, you know Portlandia people.
Right.
So and I think that there's a lot of so it seems like there'd be a lot of fertile ground for
Yeah.
common, libertarians and liberals fighting a common enemy there in big ag subsidies.
I mean,
But for whatever
there's a
reason,
lot of. I mean, this is a broader theme, and maybe this is one we can end on. There's
hmm
a real convergence between sort of conservatives and hippies. Another interesting convergence point
yeah,
is homeschooling,
yeah,
where you have the sort of hippies and sort of Christian conservatives sort of
hmm
both sort of saying, hey, the system is completely corrupt, and let's not
hmm
tinker with it. Let's either
yeah,
opt out or completely change it, which could lead us into a whole new hour. But
oh sure,
there was this. We're not going to do that. But there was this anecdote. I was with this super super sort of. I mean, I don't want to sound mean, but this particular person was completely the cliche of the San Francisco liberal hippie. And we were talking about education, and I was talking about how I was planning to put my daughter in Montessori school and then unschool her, blah, blah, blah.
hmm
And she went, and she didn't know that I was a conservative, but she said,
hmm
we really have to be grateful to the Christian conservatives because it was they who fought for the right to homeschool our kids. And she was the head of the sort of homeschooling sort of collective in
hmm
San Francisco. And she was like, I don't agree with them about everything, but we really have to be grateful to them. They're the ones who fought for this right. It was amazing. I was like, and yeah, like
David
yeah.
Sessions, if you're watching this, I apologize for making you cringe right now.
There's a big sort of thing waiting to happen for sort of Whole Foods conservatives or whatever you want to call
hmm
them. But there's a
Yeah.
sort of hippie and hippie. I mean, you know what I mean.
Right. Right. Yeah.
Uh,
No. Yeah.
yeah, and sort of fundamentalist flat earther, blah blah blah,
hmm
whatever.
Yeah.
Convergence on a bunch of issues. Agriculture is one of them. Schooling is one of them.
hmm
For some, maybe guns. I don't know.
Yeah.
But yeah, and that's the key thing about that, and we can sort of maybe sort of bounce back on this idea and maybe leave it there because we're past 4. Um, you know, the sort of Gold Hill idea for healthcare is
Mm-hmm.
sort of taking the best idea from the right, which
Mm-hmm.
is let's have sort of consumer driven blah blah blah, and let's have the best idea from the left, which is
Mm-hmm.
have a safety net and insure everyone.
Yeah.
And instead, the healthcare debate, the sort of Obamacare, but
Mm-hmm.
the healthcare debate generally is let's take the worst idea from each side. It's the line. Oh, but Obamacare was a Heritage Foundation proposal. It's not this big socialist bloc. Well,
Mm-hmm.
okay, maybe it's
Right.
not full socialism, but it's the worst ideas from each side. Uh,
Yeah.
and a lot of time, that's what our debate looks like. It's
Yeah.
let's take the worst ideas from each side, and very often what looks productive is let's take the best idea from each side, and sort of, and what that often looks like is, instead of putting the center left and the center right together, it's putting the far left and the far right together,
Oh yeah,
and that
definitely.
that actually leads to very, interesting things.
Yeah.
Sort of, oh,
Yeah.
drugs. Here's another one where far left
Yeah.
and far right are sort of
Yeah,
coalescing.
definitely. Definitely. Yeah,
So
no, and
anyway,
I think
maybe, yeah, I don't know if you also have a final thought.
yeah, just real quick on that point that I think that again to sort of beat a pretty common um, petard is just the that the I think a lot of the reason why it's sort of it doesn't work out that way is because the worst ideas of the right and worst ideas of the left proposals tend to benefit uh, the current well-moneyed interests. Big ag, big insurance, big hospitals, all of them benefit
Big doctor.
when yeah, yeah, big doctor. They all they all have a seat at the table, and they're all driving. I think a lot of the policy and the funding the policy makers. And so I think a lot of the reason why these ideas don't ever get enough traction is because people, you talk about drugs, big prisons, they continue these ideas are threats to their existence,
Yeah.
and so they're always going to be perpetuating policies that
Yeah.
will keep them along. And so, if for going back to the original thought, if doctors really want to do what's best by their patients, then they may need to give up certain things and think about how to change the system in a way, and using their power to sort of change the system in a way that's better.
That's a really optimistic thought and a really good one. I will drink to that and pray for that.
Yeah, me
Uh,
too.
you know, I don't know. I don't know if I'll see it, but I will certainly pray for it.
Okay. Yeah. Well,
All right.
I'm going to try to start it in a totally different country. Let America figure out its own problems. They already have the law
That's
and the
that's
profits.
that's one way to do it. Anyway, this was. I don't know if anybody is going to watch it, but I really enjoyed it.
Yeah, me
This
too.
was fun.
Yeah,
All
definitely.
right. Well, take care.
All right, you too.
Bye.
Bye.